Very good afternoon, and at the outset, I would like to thank the organizers, Dr. Saurabh and Dr. Puneet in particular, for this wonderful opportunity. I have been asked to discuss about the nuances of all these studies, and I have a very eminent panel to discuss and enlighten us more about the relevance of these studies. May I now call upon my panelists, Dr. Sanjay Edla, Dr. Kishore, Dr. Sanjay Surekha. Dr. Deepak Vora is probably not there. Dr. Deepak is not there. Okay, Dr. Varun, Dr. Varun Shukla, and Dr. Achita. Okay. Dr. Varun there? Okay. So we have, I think, couple of questions you will have to field. Yeah. So we'll start with the first study, that was the Zircon trial, which was Zr-girentuximab for PET-CT imaging of clear cell RCC, prospective open label multicentric phase 3 trial. Dr. Achita, I will start with you. The trial primarily aimed to evaluate the utilization of this molecule, particularly targeted for carbonic anhydrase 9 producing clear cell RCCs. Are you convinced that this kind of a molecule is necessary, this kind of a study is necessary, and what are your reasons for the same?
See, actually we all know that
Can you keep the mic a little? Yeah.
Hello. Yeah. So we all know that FDG has a very variable uptake in clear cell RCC. So it is mostly of very low grade. So we this kind of molecule, which is zirconium 89 girentuximab, it targets the carbonic anhydrase 9. So what, according to this trial, what we have seen is it has a sensitivity and specificity of more than 85% in detecting clear cell RCC basically, where FDG doesn't have much role. So I am quite convinced, but yeah, of course there.
So this was my next question. So basically, the indication, at least as on date, to evaluate RCCs has not been to utilize a PET-CT scan because of low uptake of FDG, like you rightly mentioned. Now, even this study has not evaluated the metastatic sites. So how do you think that this study will fare in comparison to FDG? It is as good or as bad, because this study has not evaluated the possibility of the sensitivity or specificity of this molecule in the metastatic deposits.
So this trial was done basically in T1 stages, that is less than 7 centimeter of lesions, renal lesions. So these are mostly indeterminate lesions, for which we are looking for another tracer apart from FDG. Whereas in metastatic cases, mostly FDG can still play a role, but where there is localized renal lesion, just the renal lesion, we have to describe it, then it's quite difficult to do it on FDG. That's FDG. Why, yeah.
Okay. But I think till availability of, the ability of this molecule to pick up metastatic disease, personally and as a clinician, I feel that there may not be a major relevance of utilizing this molecule. Any comments from the panel?
I would go the other way around. Actually, I think it has got significance, because anybody can pick up a metastatic disease. We need to have a better definition of whether this is a clear cell RCC or a papillary RCC. That's one. Second, now that we have, it works even in small renal masses, so it should work in bigger renal masses. Then the third one, when it comes to PSMA based treatment like lutetium, this would be a good one, because if it is able to home in onto the molecule within the clear cell, then we can probably try radiotherapy in that setting. So that's the reason I think it's a good enough one.
But it has its own limitation, that non-clear cell RCC, which is 25% of the all indeterminate mass, they won't be picked up. So the basic, ultimately, if we see that 30 to 40% of less than 4 centimeter mass may be benign, then some major chunk of it is also, part of it is also non-clear cell. So again we will miss that. So ultimately we will end up with a biopsy if even this molecule does not pick up. And Sarah has said regarding the therapy, actually I think it was 10 years back this molecule came as a target therapeutic agent for clear cell RCC, but ultimately it was insufficient.
Yeah, it has not taken off.
So yeah, if it was not taken off that time, I don't know again it will take off or not.
I think no, from a diagnostic standpoint view of a primary renal mass, you don't require a PET CT because
Exactly.
most of the CT and MRI will clinch the diagnosis. It is 95 to 97% accuracy, which is probably more than the PET. So the question is that whether the FDG compared to FDG, this PET type of PET scan is better. So we need a head-to-head comparison, just like FDG PET for prostate cancer comparing to PSMA. So if you have a head-to-head comparison, then probably we know whether it is really better or not.
Okay, Dr. Varun? Yeah. So this question was for you. They did a 5-day prior, injection of the molecule. Was this required?
So,
And yeah, I have a few questions for you.
so here the issue is that there is time to localization of the molecule within the lesion. If you have to take care of that, then this delay is required. Any larger molecules such as trastuzumab or girentuximab, these take some time to localize to molecules and for the background to clear. Therefore, this delay is required. They have reported as a convenience that the patient can come at any time, 5 plus minus 1 day, but with FDG, actually it's better that you inject and you do the scan at the same time.
Immediately, yeah.
This becomes kind of an inconvenience for the patient because they have to independently visit twice.
Not only that, I'm sure that, with the limited amount of patients that are studied, we do not have robust idea about the elimination kinetics, absorption or the elimination kinetics. So we are really not sure whether we are actually missing out on something, or what's your take on that?
Yeah, that could be a reason, but usually elimination kinetics is done in preclinical studies and that is in some ways reflected in human studies as well. So I do not think that it would get cleared off from the lesions as well within the 5-day period. If 5 days is taken with as an uptake time, then that should not be a reason. But yes, 5 days is a pretty long time, and the patient, if he is coming from far away, has to travel back and back again for the imaging. Another limiting fact is that the radioisotope which was used for imaging is not available widely. So the whole procedure which we are discussing right now, both girentuximab and zirconium are not easily available, and therefore reflecting it in Indian population is very questionable.
Yeah. Dr. Rachita, this was for you. I think Dr. Sanjay has already partly alluded to this. How does... Yes, sir.
As we are talking about this carbonic anhydrase, I mean, this has been going on for the last 25 years or so. Having said that, for this trial, if I were to be there as one of the initiators, I would have also done a biopsy of this. And same time you could have, because ultimately everybody went through the procedures in terms of excision, either partial or total nephrectomy. I would have done a biopsy, whatever, true cut guided biopsy, and then try to look at that thing as well. That would be my suggestion.
Okay. Do you agree that there's a significant proportion of patients without clear cell RCCs also producing carbonic anhydrase?
Yeah, that's true actually.
Again, bringing down the validity of this particular molecule.
Trial, yeah. But in this trial also they have taken around 300 patients.
Correct.
In that chunk we have seen very less number of patients with papillary or other who has shown expression.
No, but this is historical data that up to 20% of the patients can, with papillary RCCs can demonstrate.
Yeah, they can show uptake. Yeah, that's true.
Dr. Varun, any specific clinical indications?
Only larger renal masses which are indeterminate on conventional imaging, those can be taken up for this scan. And if the biopsy is risky in those procedures, those patients can be taken up for this kind of imaging.
Any clinician perspective on this?
Regarding FDG PET scan or regarding?
No, regarding this scan. No, if at all, it comes back into use and then it's available to you, which would be that patient where you would be very happy to use this scan?
It depends on how this molecule will taken up in metastatic setting. If at all it takes up, then probably to evaluate the response to therapy, early response to therapy may be a very specific area where this can be very useful.
So
I
that's
don't know.
what I came out with a few points. I may be wrong. I'll just list them. Indeterminate small renal masses, where we are not able to biopsy. We don't know what's happening. Then ambiguous extrarenal disease of concern for metastasis, some small lung nodules or some bony lesion here and there which cannot be biopsied. These are probably two.
As in currently all diagnosis for renal mass is based on anatomy. This is an attempt at trying to find a molecular basis or a biological basis. So let's say that this is taken up and there is a SUV max is higher, then probably we can relate it to grade. So somewhere along we need to find a way of having a biological study for renal mass compared to an anatomical one, which is what we are using now.
One specific indication where the inflammatory mass knows like XGP something which can mimic cancer. Probably FDG takes up both.
Yeah, correct.
So in that instance, this might be helpful because if it doesn't take up in the inflammatory picture, I don't know.
So this is the next paper that was presented, Comparative Efficacy of Cryoablation versus Robotic Assisted Partial Nephrectomy. It was a systematic review and a meta-analysis. They reviewed a lot of papers and then finally narrowed down to including 10 studies with roughly 2,000 patients included. I will not go into all this. I'll start the questions now, Dr. Sanjay. What are your concerns when you offer ablative therapy to your patients? Are you happy to offer on a routine basis, or are you concerned?
Of course, on a routine basis, this is not the first choice of therapy. In patients who are not a suitable candidate for surgical candidate or not willing for surgery, they have an option of giving ablative therapy.
No, but when you do send, what are you worried about?
The worry is because I am not personally giving this therapy. It is given by the intervention radiologist. So there, of course, if you are not doing something and it is being done by somebody else, you have a concern. Because the kind of ablation they are doing is in my center, they are doing only radio frequency ablation. So in a little larger mass, in a smaller mass is fine, but in little larger, more than 4 centimeter, 5 centimeter mass, I often seen that they ask for multiple setting. One. Second, if there is a major necrosis, then again it is a very problematic. Third, evaluation whether it is really ablated completely or not, it is again a challenge. So there are many challenges.
Can I just,
Yeah.
the last point that he raised, so whenever we are offering a treatment, there has to be some predefined way of knowing whether it has worked or not. Currently, we don't have one. Whenever we were doing RFA in England, all the MRIs had to be sent to the main people and they would say, it looks fine. For us, when we looked at it, it didn't look fine. When we look at even the ones that are there, cryo, RFA, and now SBRT. SBRT is graded with RECIST criteria, not with respect to whether there is a lesion or enhancement. When you give an SBRT, my understanding, there are radiation oncologists who are more learned. The lesion will be the same. The enhancement will be the same. It doesn't increase in size. And even with that one, there is a 10 to 20% that is allowed to increase. So what I won't know is when I refer a patient, if he comes back to me, I don't know whether it has worked or not. And that is across all, whether we say prostate, HIFU or any of them. We don't have a defined way to say whether it has worked or not.
Yeah, precisely the point. I think summarizing from what both of you have said, the concerns are incomplete tumor ablation and residual tumor tissue. We really do not know whether there is residual tumor tissue or not. There are technical limitations and variability in procedure because it's an evolving practice. The tumor characteristics and size considerations play a very big role. If the tumor is in a very difficult to access location, even for the ablative treatment, then complete treatment may not be possible. And of course, operator experience, and this is universal even for a surgeon. So all these are the critical concerns for patients undergoing ablative therapy. Now, if you sent, would you say, okay, this is a size, I am not going to send you for a cryoablation or whatever. I would just stick to ablative therapy, any ablative therapy. Would you say, no, I am not going to do this?
Yeah, anyway, any size, if patient is suitable for surgery, I don't send. But
No, this is probably only for patients who are
yeah,
not
but
suitable.
any mass which is T2 and above is T2 and above is I am not comfortable, because even in my center the intervention radiologists are not comfortable. They say that anything above 5 centimeter I am not comfortable. So I am also not comfortable.
Any comments?
It's more of are you in a position to pick up the complications is where you are looking at. Let's say you have got a central mass, a lesion in the lower pole of the renal mass close to the ureter or something very close to the vessels. If you give RFA and they have a complication, it is you who has to go back and deal with it, not the interventional radiologist. So those would be my concerns. If it is an exophytic, mid-polar, outside, nothing is going to harm.
You are happy to send
Do
them.
whatever you want.
Yeah.
But if I'm not in a position to deal with the complication, you're only sending them because you can't operate or you don't want to operate. And then operating, it's like a post-radiotherapy operation. If you didn't operate it at the beginning, you are not going to operate it after RFA. So those would be my limitation. If I can't deal with the complications, I won't send it.
Yeah. Dr. Kishore, I think these are the only 3 that are available in India as of now.
Yeah.
Correct me if I'm wrong.
No, I had the opportunity to work a lot back when I was in US actually. So I did research on VX2 model in rabbits. Okay, so where we created this tumor and we operated on the rabbits after two weeks. So the tumor will be around 3 centimeters size. So I've experienced with RF and cryo. The cryo, ablation zone is very poor. It's very ill-defined. It produces massive reaction. So that's why gradually it's fallen out of favor. But RFA is much more robust. You get a very circular ablation. The issue with all these ablation modalities, I don't have experience with microwave, but predominantly we did with RF and cryo. No, at the peripheral zone, it all depends on the temperature. In RFA, we have to attain a higher temperature. In cryo, we have to attain a lower temperature. So in the larger tumors, one single ablation will not be sufficient. Say the more the tumor area is, so we have to do multiple ablations. So there is more likely that some areas are going to be missed completely. So it's not suited for larger tumors. Maybe I would say I would provide a benchmark with that modality around 3 centimeters, not more than that.
Not more than that. So I would just like to share our experience. We use microwave preferentially over RFA, and we have done 8 patients till date, not many. And all the 8 patients have done very well short term. The longest follow-up we have had is about 3.5 years. They are all doing short term, but like Sanjay sir mentioned, the radiologist also doesn't know what's happening. I also don't know what's happening. We see the image, we say that the size of the tumor has not changed, and therefore everything is well. So maybe long-term data will tell us how
So
these
I
are going
just
to.
want to make one comment regarding RFA partial nephrectomy. There is one patient, I had a solitary functioning kidney, and patient was not willing for partial nephrectomy because the risk of radical nephrectomy and all. So he underwent RFA. Subsequently, I tried for partial nephrectomy. It was a hell lots of difficulty. So
Yeah,
then I
that
have
was one of the
converted from
questions that I was going to
robotic
ask.
robotic to open, and finally I have done it, but it was really difficult.
So this is a chart for our younger colleagues, comparing all the 3
Dr.
modalities.
Yeah, hi.
Yeah.
Hi, Prahlad. Why not SBRT is an equally effective modality? You said these are the only 3 options. I would like to pitch
No,
that SBRT is also an option in the non-operative setting.
Right now, I think the SBRT has been approved only for local control in a metastatic disease.
It's a non-operative option.
No.
There
What
is no
I'm saying
randomized
is,
trial.
I have not factored in SBRT in this discussion because right now there is no data for treatment of a primary, curative disease.
Okay.
So it is only for metastatic. That's the only reason why. Obviously, I am sure SBRT will be very beneficial. There are a lot of talk now saying that SBRT opens up the potential for immunotherapy, so on and so forth. So I think a lot of exciting things happening with radiotherapy as well. But this is only for curative small renal masses. So that's why SBRT has not been included in this discussion.
So what about IRE and HIFU in this?
I did not include because it was not available, so I thought we wouldn't have much experience regarding it. That's what the reason why I said I just included these 3. So this was a question for you, Dr. Kishore.
Can I just...
You have already answered
sorry,
this.
Can I just go to the previous slide? When you look at the cancer-specific survival
Correct.
for active surveillance for a SRM is 99%
Better
at
than
10
this.
years.
Yeah.
Yes? So though it looks like 90 to 98%, these people are not going to die of that disease. However we do it, these are like the low grade renal prostate cancers. So it looks very nice saying that cancer specific survival at 5 years. I feel 95% is very low. It should almost be closer to
like
I understand.
Data. Yeah, but the other point I wanted to bring in here was that the true beneficiaries of ablative therapies are those patients who have a renal mass sized between 4 and 7 centimeter with a propensity to progress, with a propensity to metastasize. Any small renal mass less than 4 centimeter would do as well with active surveillance.
Yes.
So the whole discussion is whether ablative therapies will be effective in this 4 to 7 centimeter subgroup, which probably is not the case. Sir, any specific, you already told that you prefer to do an RFA, and these are the cases probably most suitable. Just summarization that in a solitary kidney, in a complex location, in a CKD patient where partial nephrectomy may not be feasible, early recurrent tumors post partial nephrectomy, less than 1 centimeter, 2 centimeter, very sure that it's a recurrence and then you want to treat it. Very elderly patients, these are probably the candidates for ablative therapies. Sir, Dr. Sanjay has already mentioned his difficulty. Have you ever encountered any difficulty like this, and what's your experience?
Yeah, if I have ablated it first time, I'll send it for reablation. I'm not going to be brave enough. If I didn't operate first time, surely I won't be the other Sanjay and say I will go and do a partial.
So do you think it's a valid option, reablation, and how effective is it?
As effective as the first one?
You're reablating, so...
Because as Kishore has mentioned, it has failed because a part of it hasn't been ablated. Because once you have ablated, you know that it's like excision, you have killed it. So just that the technique wasn't good enough in that you haven't covered the whole lot, rather than saying that that is heat resistant tumor. Whatever you have ablated, I think has died. So you haven't ablated that part, that's why they have recurred.
Yeah.
It sounds nice, so yes.
Yeah.
If patient is not willing for reablation, then what you will do?
I'll send it across to northern part of it. I have done partial in post RFA sort of patients, but it's more of, it's the same. If you haven't done a cystectomy in the primary, you will struggle to do it in a salvage setting. It's the same with this one.
Yeah, so these are some of the challenges that I wanted to highlight, and I'll just, for the paucity of time, these are the challenges with reablation. Very limited data, what we have, but whatever papers are there have shown that reablation is a good, effective technique, can bring cancers back in control for reasonably long periods of time. That's the summary. This is the third paper, very exciting paper, unfortunately.
Can you just make a conclusion? Majority of this one, when you have ablated, when they have recurred, preferably reablate. Because whatever the reason that you have sent for ablation is there, going for surgery would complicate them quite a lot.
Absolutely.
So,
yeah. So this is the third paper. Now we have OS data available with the Keynote 564 trial. No other trial in the adjuvant setting has actually offered any OS benefit. Sir, are you convinced?
the numbers sound as though I should be convinced, but I am not convinced. I'll give you a
Why?
I'll give you a typical example. You do a partial nephrectomy for a 4 centimeter mass in the hilum, infiltrating into the hilar fat, T3A, grade ISUP grade 2. According to them, which are 80% of their cases were that, you should be sending them for immunotherapy. Because they have just taken it as T3A as a baseline, irrespective of grade as an indication. And quite often we find T3A, margin clear, grade 2. Then you say, am I sending these patients for adjuvant treatment? That suggests that I should be, but I don't. Whereas if you do a radical nephrectomy, that is the gerotofat is involved, T4, yes, there is a risk of metastatic disease. So I think there has to be a differentiator between, am I worried about local recurrence or am I worried about systemic recurrence? Post-radical nephrectomy, patient who has got a large bulky mass, I'm trying to prevent systemic disease, that's when the immunotherapy would be better. So which subset, the patients wherein I'm worried these people would have systemic metastasis is where I would advise that rather than local.
Yeah. So these are the parameters. Anyway, I'll just keep it for the paucity of time. This was the point that I wanted to actually ask you. You know, this is probably the most of the cases that formed up their trial. So if we now do a partial nephrectomy with high risk, would we be having to send all of them for adjuvant immunotherapy or not? My preference would be not. I think even Dr. Sanjay agrees. Anybody else in the panel? Kishore,
I
sir?
don't understand that. Probably there are more intelligent people there. What is intermediate high risk and then high risk?
Problem is on the family member. If the unfortunately that PT3 patient recurs back and the family member has heard about that there is a benefit, then they will say that why you have not been offered. No, sir.
That was
since Dr. Deepak is not there, I will ask you this question. If there was a case of partial nephrectomy, T3 disease, margins negative, sent to you for reference, will you give adjuvant or not?
For giving an adjuvant in pembro, they all node positive T4. T3 grade 2, maybe I will not push for that. I will give them suggest an option that this is the option, but the magnitude of benefit may not be that much. But we have to tell them this is the approved indication. We cannot say that no treatment. We have to tell them these are the options.
No.
The magnitude of benefit may not be that much.
No.
Dr. Srivatsa, if I can have.
Yes. So if you are telling a small renal mass, 2 centimeters, with maybe perinephric extension versus a large renal mass, would have been a radical nephrectomy, T3A, or is it the same?
That's where I was trying to allude. So, Amit, just answering your question, do I offer them adjuvant therapy? I say, yes, there is a role for adjuvant therapy, but I feel the amount of benefit you are going to get is less. Yes? So, that clears
Now,
that
sir,
relative
that's
also.
very subjective, because here, I'm just debating here.
No, sorry,
Don't take it as my personal
I'm not.
preference,
I've
but
just
what I'm
wanted
saying is it's T3 disease, after all.
Yes.
Now, why are you differentiating 3 centimeter T3 from a 8 centimeter T3?
How is the classification system made? What I'm saying is the KNM classification?
It's limited.
Yeah, no, it's not robust. We know that. In fact, sinus involvement carries worse prognosis than renal vein involvement, and we still are looking at the T3A for sinus involvement.
But I think if you look at here, most of the patients were not high risk, they were intermediate high risk. Despite that, there is an OS advantage 5%. If there were more, the advantage would have been more as per your,
Yes.
right? If there is an advantage in the overall survival, 5%, with most of the patients belonging to that, we should be offering the benefit in those subset may be smaller, agreed. But I mean, that's more of a informed decision to the patient that there is a benefit proven, but I feel that there may be less. That's what you're saying.
Yeah,
Right.
exactly.
No,
Dr. Anand.
Yeah, I feel like a gramophone record that stuck. Again, this was a grossly flawed trial. Lot of fallacies in this trial. The standard of care for patients who recurred, this study got over in 2018. The time at the study got over in 2018, the standard of care for patients who recur was a doublet therapy. Patients would have got pembrolizumab plus a TKI. For Merck should have sponsored TKI plus pembrolizumab for patients who recurred. Less than 50% of the patients got, no, 50% at the original product, now it's 70 now in this update. The 70% also, we don't know when they got the pembrolizumab, whether they got the pembrolizumab at first recurrence, whether they got sunitinib at first recurrence, whether they got pembrolizumab at the second recurrence, or whether any of those patients actually got even a doublet at any point in time.
That is the problem of all.
No, sir.
90% pharmacy crossover is not, the company will not crossover.
If the patients did not get the standard of care that they needed to get, obviously.
That is the flaw of all the pharma trials at the
So
time of
that is what I'm trying to say. It is a
whatever the
pharma-driven
standard
trial with a lot of fallacies in this trial. The overall benefit, if you see, is going to be very, very, very small.
5% is a big benefit.
No,
but
that 5%
having
benefit is
said
after
that-
the control arm has been depressed so significantly.
Yeah. No, but having said that, it is very unfortunate that a similar drug acting on a similar pathway has not shown benefit in any other trial.
So that's the reason that
So
they
that is
did
the
not show
whole
trial,
reason
because
why,
the
we need to
comparator arm
accept
was
this
very,
counter
very
to
bad.
that the adjuvant nivolumab has shown the benefit in bladder post surgery. If it is PT2, why PT2. So we cannot just say that adjuvant immuno doesn't work. In esophagus it is working, in lung it is working. So I think we just cannot immediately say that.
Sir, I am not saying it's not working. I am saying that the trial design was not good enough to say that the adjuvant therapy is working. That's
I feel that as a clinician, it's our responsibility to choose the patient wisely. So for a PT3,
sir, I am only trying to say, I am only talking about the trial design, which was grossly flawed.
Amit, so that's what I agree with your last sentence, in that it's an informed decision. I inform the patient and I decide.
But send to us. Let us have a talk to
okay, now I think we are running behind time. We have two more papers to discuss. So, is adjuvant, there is no roles. I mean, right now there is no study, basically. Right now there is no study. Maybe it will come up. Yeah, now Dr. Amit, I'll just ask you out of turn. So, in the past, you would always say, do a PDL1 assay, favorable that this, all that, 5%, 10%, 25%. Now, the trial says that regardless you use it. So, what's your take on that?
I think at this stage, I think nobody does the PDL1 in this. So, all patients, so mostly pembrolizumab all over except the esophagus, you'd see the CPS score. Otherwise, it's all irrespective of the PDL1.
So, you believe that pembrolizumab will work on all patients, regardless of their PDL1 expression?
PDL1 is one of, so if you say the markers for a immunotherapy response, the best one is the MSI. If that is proficient, then it will work. Otherwise, for PDL1 may or may not be, MSI may or may not be. So PDL1 and MSI are not, or the TMB are not the marker to decide. So it may or may not work. It has seen in other tumors also. PDL1 is one of the marker.
Can I just ask, why is it intermediate high risk and there is a high risk? It just, whenever you tell the patient you are intermediate high risk, they only listen to the high risk. They don't listen to the intermediate
human psychology.
Risk.
So if you say the high risk, then...
No, but why are you, when you are grading it, medical oncologist who has devised patient falls into the intermediate high risk group. No, he doesn't fall into the intermediate. He falls into the intermediate. There is another high risk group.
So the highest would be the M1 and ED. That may be the highest.
One I agree. So, everybody should be going.
Node positivity may be the region. Maybe they have put it that. So I think why they have planned it we might not be the right people to say why they have put in the intermediate high, why they have not put only the intermediate. So I think that is the way the word runs. Yes.
Dr. Kishore, you wanted to make a point.
Keeping away all the trials, if you have to choose one agent for adjuvant therapy in renal carcinoma, which one you use?
Pembro. Till this point of time, pembro.
Without the evidence, say if you're treating in metastatic disease also, which one gives the better response? Pembro, Nivo, whatever you use.
Mostly the IO in the metastatic scenario, mostly the Nivo EP and the Pembro, these are the drugs which have been...
I think Nivo lenvatinib is also doing well. That's also another combination.
So it's all the same?
Anyway, now...
it's the luck, by chance of a Pembro, it is everywhere working except few places it is negative. Otherwise, Pembro is everywhere working. And why it is working, why Nivo is not working, both are PD-1 inhibitor, nobody knows the answer for this.
Dr. Saurabh, I think we are running out. We have time? Okay, great. So, again, sorry, out of turn, I am asking Dr. Amit again. We are now seeing a lot of these variant RCCs. I think we share two common patients as well. So, how do you think that, adjuvant plays a role in these settings, and should we be offering them? If adjuvant works without PDL1 expression, why not in FH deficient?
Basically, it's an immune mediated phenomena that might, so that is the reason when even in a metastatic setting, if there is a papillary with sarcomatide, we are pushing for the immunotherapy, because that is the nature where the T cell will work more better and the tumor will be better controlled. Papillary, the pathway may be, it may not be the pathway where it is working. So as such, except for clear cell RCC, if you compare the data of EP-Nivo in the non-clear or papillary, the PFS benefit or OS benefit is not of that magnitude. For a FS deficient tumor, there is no data. So
now, see, there has been no data for long. We still do not have data which is the right patient to use or not. But we are using it in them. Why not here?
Word runs. So if there is no trial for a immunotherapy in a papillary setting, and whatever the little bit data for other from the where the patient of papillary has also taken in the one of the studies. So I think if that is negative, we have to take it as a negative. And we know that the pathophysiology of a clear cell will be different from papillary to the chromophobe to the FS deficient tumor, and where the immune system is not on the upregulated. So that may be the reason the immuno has not been used. The other reason it's not that common. So for a pharma company to do a trial where the number of patients are very less, that might not be financially feasible. It may be, we don't know. But there will be no randomized study since there's not a segment for that. Therefore, the institution or the educational institution should come, but you can't do even for a low dose nevo trial. You have to go for a 4-5 crore budget.
So I'll move to the next trial. Sorry, I don't have the slide here. This is the topic regarding relevance of positive surgical margins in localized RCC after surgical resection. I'll start with Kishore sir. Sir, what do you do in case you have had a patient with positive surgical margin? What are the factors that you consider?
It depends on the extent. Say, in cases we have left a part of tumor, like without a knowledge.
So gross positive margin.
Then there's a chance that recurrence is bound to come. Then we go ahead and have to have a completion nephrectomy. Okay. And in case
completion nephrectomy, or would you just go back and try to revise?
It's going to be hard. I think
it's going to be hard.
Nephrectomy would be better. And second possibility is that, say, by without your knowledge, you have just slit open the capsule and then you send it for pathology, the formalin nicely paints on the ink, then it could be spurious positive margin. Okay. So that cases you can leave if you have deliberately made a, that there is a violation of the capsule, then you can probably wait. And then the grade of the tumor. If a positive margin, a lower grade, probably you can wait. Higher grade, you have to intervene. And also, if a positive margin is the sinus, they are more risky, you need a closer follow-up.
Okay, so there are several aspects that we need to consider before taking a call on how to deal with positive surgical margin. I think one of the initial steps that we would encourage is to have a discussion, multidisciplinary tumor board discussion, and then, like Dr. Kishore mentioned, assess the extent of positivity, the unifocal, multifocal, what is the grade of the tumor at the margin positive status, and overall tumor characteristics, so on and so forth, whether the patient is affordable for a constant surveillance or would want a one-time treatment to sort out the problem. All these things, ability to take adjuvant therapy, so on and so forth. Here is probably one question that I would ask the nuclear medicine people. Madam, positive surgical margin clear cell RCC, would you recommend Zr-girentuximab scan for surveillance? No, I mean, I had not kept you busy for a while, so I thought.
See, for restaging of RCC, we usually use FDG. That's quite good because it takes up FDG uptake.
No, it's going to be in the operative bed, so probably early pickup.
See, FDG has a physiological excretion through kidney, so that in that case, obviously, yeah.
What about PSMA PET for RCC?
PSMA PET is used on the basis of neoangiogenesis basically. So in that case, it is not very specific to RCC as compared to.
Yes, there are studies.
PSMA also shows uptake in postoperative changes. It's not like a specific that it will only show primary tumor. Maybe it may be better, but PSMA also has physiological uptake in renal cortex. So we'll have to be very clear to delineate the primary tumor in PSMA. FDG, and also the problem with FDG is that many of the time, at least in clear cell RCC, FDG can be negative. Right? In clear cell RCC, FDG can be negative. If it is like a, if some cases like where this is like a FBP positive tumors, those cases where there is like the glucose metabolism has changed, less neoglucogenesis more neoglucogenesis is happening. In those cases, sometimes FDG may be positive, but most cases FDG may be negative. So FDG is definitely not a good tracer for this. PSMA may be, but we'll have to still look into studies and such. And as Zr-girentuximab was asked, I don't think Zr-girentuximab is ever going to come in India. Because
no, that's why I said if it all is available.
It is never going to come because we don't have the zirconium, the trace, zirconium we don't have. And Telix specifically made it to market in US. So, and it is like pretty costly. But there are a few other targets like for carbonic anhydrase, small molecule targets, DPI 4452, and there is one NX203 target. So those are being explored, one in US and another in Australia. So few studies have come up. They may come in India, and they can be labeled with gallium. And if they come, then they probably would be good.
So regarding your question, whether Mike.
No, I mean, hypothetically not a gross margin, a small focal margin.
So, regarding your question, I'll first answer Sir's question. Your question regarding local recurrence in zirconium. So, the authors did a phase 2 trial before this, and they showed that Zr-girentuximab actually picks up local as well as distant recurrence in operated cases. And regarding Dr. Sanjay's question, would you do frozen section while doing a partial nephrectomy?
In any scenario?
Generally not. Generally not. We have given it up long back, and we have not found a major difference. Yes, sir.
Recently, I was involved in a case, and Shrikant knows, he was there also. We had a VIP patient, and medical person was in the field, in the sense he was there during the surgery, and somehow he influenced us to do a frozen section. To the tune that he influenced the pathologist as well. And we were told, pathologist called me and she said, I'm seeing some eosinophil cells. This guy says, no, it's cancer. Then I had to revise the margins. Then she said ultimately, no, margins are clear now. Ultimately, lo and behold, at the end the report was oncocytoma.
Okay, I think we are running out of time, so I'll be a little fast now. Dr. Sanjay, this is for you. Do you change your protocol once there is a patient with positive surgical margin, or it's a standard follow-up protocol? Quickly.
If it is a microscopic positive surgical margin, then it depends on the grade of the tumor and the nature of the tumor. It is a papillary, clear cell RCC, and so many factors. So usually if there is a positive surgical margin, at least for initial 2 years, I keep them in more stringent follow-up than conventional.
So I think the other part of the question was already answered. There is a small role of girentuximab scan if there is one available. This I think the medical oncologists have already discussed that it is a guarded decision whether we use adjuvant immunotherapy in these cases or not. And I'll skip that. I'll just come to the last trial. I unfortunately did not have access to the full paper for this, but this is a Neotax, a phase 2 trial of neoadjuvant toripalimab plus axitinib for clear cell RCC with a resectable IVC thrombus. So these are patients who had IVC thrombus which were operable and were administered these two drugs in the neoadjuvant setting. Adla sir, how often do you use neoadjuvant therapy in patients who you feel are resectable upfront?
Never is the answer, because you would do it. Let's say that a patient has got a single kidney, has got a 7 centimeter mass. You would say that yes, that is resectable, but the amount of risk I am taking is a bit higher for the patient. In which case you would do a biopsy, give them neoadjuvant so that it becomes 4 centimeter, because of which the probability of you doing a partial nephrectomy is higher. So it was resectable before, but it is more easily resectable in the second setting.
Kishore sir, any case you would?
No, like if in a level 4 where the morbidity is prohibitively high, I think in elderly patient we can try this.
How often, we have tried it in a few level 4 patients. None of them showed regression. We had to still take them up for bypass and complete the procedure. How often do you see disease regression altering the way you operate?
Yeah, because we have only 2 cases in our experience, so both were at the atriocaval junction. In fact, after 6 months of I think nivolumab, this is regressed, thrombus, but it's still there in the atriocaval junction, so it's not really going to alter the surgical extent of surgery, I would say. And on the other hand, probably it might make our surgery more difficult because thrombus, because of desmoplastic reaction and this fibrotic reaction. So I think as of now, either way, it's like.
So you do not prefer whenever, and there is an operable case, you would just want to go in and operate.
If the patient is fit enough.
Yeah, except when Dr. Sanjay sir said that you want to try reducing the burden of the tumor to convert a potential radical nephrectomy into a partial nephrectomy.
One question for that scenario, solitary kidney, large lesion, and you want to do a partial. So what would be the new adjuvant drug, sunitinib versus immunotherapy, for how long? And is there any difference in the surgical, when you do the surgery, TKI versus immunotherapy, the bleeding, the fibrosis and all of that, your experience with sunitinib and immunotherapy?
So when you don't know, you ask people who are a bit more intelligent than you. So I called Raghavan and Raghunath and said, what do you use? So Raghunath said he has done this in 12 cases. He has used axitinib.
Yeah, we have used axitinib.
So I've done, and by 3 to 4 months, he says that the size of the lesion does decrease for you to make it feasible to do a partial. So immunotherapy, not currently, just because the duration that you have to give it is a bit longer. You need minimum 6 months for it to show any effect. So currently axitinib is the one.
Single agent,
single agent
3 months reassessment.
And the duration of stoppage is also less. Only 3-4 days before your surgery you can stop it, because of which it's more easier for you to operate.
This, like he said, we have been using axitinib in select cases, and there are a couple of points that I wanted to mention. One, axitinib definitely reduces the size of the tumor, can potentially convert a radical nephrectomy into a partial nephrectomy, but there are certain challenges with axitinib as well. Unlike you said, sir, we need to stop axitinib at least 15 days prior, and restart it only if required, only after a month.
Right.
So, in couple of patients, we actually saw, we wanted to wait for a month, and we actually saw an increase in the size of the tumor within that 1 month span.
Okay. So in those 14 patients in whom Raghunath sir started axitinib before a partial, he did a biopsy to confirm.
Yeah, I was involved, so I'm telling you, we have done a biopsy.
Okay. And does the surgery become more difficult?
It is definitely a little more difficult. And the second point about immunotherapy, Dr. Tushar, that I wanted to mention is, I think medical oncologists will agree, in the process of immunotherapy, there is always a phase of pseudo rise, increase in the size of the tumor, and this exactly correlates between the 3 to 6 month period when you would be very keen on operating. So giving a neoadjuvant immunotherapy will make your surgery more challenging than otherwise. So immunotherapy as of now may not be a good choice. We have used axitinib, people have used sunitinib as well. So
the surgery becomes very difficult with sunitinib. Bleeding and all is very much, that's why I wanted to know with axitinib.
So actually what happens, if we see from the
tumor becomes very hard and fibrosed. Yes. Take out, yeah, exactly.
Yeah. Sanjay, you wanted to make a point. Yeah.
With you. You see it's working. No, hold it closer.
Hello, this is working, right? So basically in 13 patients we have given sunitinib and or pazopanib. It's a para study. In the 30%, 3 patients there was significant reduction of the thrombus level, and 3 patients the thrombus increases. The level has progressed, and rest of the patients remain stable. with the immunotherapy, I have 4 patients I have given immunotherapy with IVC thrombus. Those, the patient are not suitable for surgery because of performance status, or it was a grade 4. Ultimately, after 4 to 6 months, their performance status improved so significantly, then patient was suitable for surgery. So this is one benefit I have found in immunotherapy.
Yeah, quickly, Kishore sir.
Excuse me. I was hearing that pembrolizumab, with pembrolizumab or any immunotherapy, we cannot operate at 3 to 6 months. The problem, we need to take example from lung cancer, where standard of care is to give 3 to 4 cycles of immunotherapy in resectable setting and then followed by surgery. So I don't think there will be so much of pseudo.
No, see, there is a difference between lung and kidney. Lung is a more softer organ. It gives us a zone of, you have a zone of additional resection possible compared to kidney, which is a more rigid organ, a smaller organ, and with limited opportunity to either preserve or remove the kidney. So we cannot compare these two
And also,
settings.
if I want to get the highest response rate in terms of downstaging of the tumor, if we see the data from metastatic setting, pembrolizumab plus lenvatinib, that has the highest CR rate and highest overall response rates. So we'll take the help of that. If you refer to medical oncologists, but definitely if you are giving yourself, most likely if you are comfortable with axitinib, it is fine. But if you take opinion...
No, this axitinib thing we have started long back, sir, when immunotherapy was not even there. So we just stuck to it, that's it.
But if you take a comment from a medical oncologist, I think Amit Joshi sir, you will agree?
Yeah. Yeah, I think, sir, I have just about 5 seconds. We have already overshot. Just 2
sir,
questions.
The only, sir, the thing that the trial you were saying you did not get the full paper. Actually, the Neotex trial in that they are showing that the combination immunotherapy plus axitinib, in 61% of patients there is a reduction in the tumor thrombus level, and there was a change in the type of surgery that they were going to do for the baseline. Out of 9 patients, I guess 5 patients did not have to go for that atrial bypass and all these things. So yeah, I think the IO plus TKI combination should be the one which may help in this scenario.
So level 4, basically, level 4 thrombi where a patient has to be on a bypass upfront. Maybe these are the cases. Sir, very quickly, just last 2 questions. What are the surgical challenges? Because you do a lot of these robotic surgeries even for atrial thrombi. So
surgical challenges, I think, mortality is much less when it's at level 3. So if you don't have to go for the bypass. So most of the patients we can safely resect unless they don't have a chronic liver disease or they don't have high cardiac disease or anything. I mean, probably you can do it quite safely. But when it goes into the heart, I mean, level 4, then it's more challenging. So that is what, say, if I say that it's prohibitively high, the mortality, then at least to give some bite time, more than a neoadjuvant treatment, it could be even a primary treatment for elderly people, so that they live for 1-2 years, they can live peacefully for that year. That could be probably the indication right now.
yeah, I think our time's done. So thank you very much, all panelists. It was last question. Okay, Dr. Sanjay.
Salvage option in case.
What are the salvage options in case you go in and find out that you can't operate?
If I can't operate, then I will refer to oncologist. This is the only time I refer to oncologist.
Okay, I think we'll stop there. Thank you very much.